Orthopedics for the primary care specialist. And we're delighted to put on a course like this. We felt that it was a much needed course in the community and something that was lacking. And we really appreciate everybody's enthusiasm and the big turnout that we have today. And sort of the way the course is structured is that we're broken down basically into different anatomical areas where we're going to have didactic lectures. And then at the end of the didactic lectures, we'll do breakout sessions where we're going to have case discussions and we're going to teach shoulder and knee injections, et cetera. So when it comes time to a breakout session, we're going to have you divided into 5 groups. So if you look at your name badge, there should be a number on the bottom of the name badge. Group 1 is going to stay in here, and then the remaining groups will go out into the hallway, and they're separated. Group 2 will be down at the end in the Brady-Shin auditorium. Across the hallway, 3 and 4 are in auditorium A and B, and we'll have signs and be directing you, and 5 will be over here in auditorium B. In terms of the packets that you have, you'll see an evaluation form in there. And if you could please fill out your evaluation form, that's important for the CME, and then you'll get your CME certificate. And if you could just, do the appropriate ratings on there, but the form should be in your packet, and we've included a pen in there. And there's also a little bit of information in there with face shots of all of our lecturers and the members of the department who are participating in the course today. So I encourage you to interact with everybody. If I could be of any assistance, please don't hesitate to approach me. You also have my card that's in the folder with my cell phone number on the back of it. So if you ever need to get in touch with me about anything, feel free to call me personally on my cell phone. And what we're going to discuss first is I'm going to talk a little bit about orthopedic oncology, but I just wanted to tell you a little bit about Morristown Orthopedics. We're really we thought we were a very good choice for running a primary care course because of numerous things, the volume and the quality of the attendings that we have taking care of patients here. We have approximately 100 orthopedic surgeons on staff at Morristown, and they're all outstanding. Everybody, in my opinion, is a grade A surgeon. We have 9 subspecialties, including orthopedic oncology, and there's really no orthopedic case that we can't take care of at Morristown Medical Center. We do 11,000 orthopedic surgeries a year, including 3,500 total joint replacements and 2,200 spine surgeries. And we have orthopedic oncology for pediatric and adult patients. We're really the second busiest orthopedic program in the New York metro area. And we have 5 stars with our Healthgrade ratings across the board, meaning that given our patient population and their comorbidities, that our outcomes are better than you would anticipate. And when you compare us to many of the institutions across the river, we're surpassing them in many regards. So I'm going to talk first a little bit about orthopedic oncology and musculoskeletal tumors as a cause of pain, and then we're going to discuss neck and back disorders, and I'll ask each of the attendings that come up to give their presentations to introduce themselves. So I'm James Wittig, I'm the chairman of the Department of Orthopedics, and one of the questions that always comes up to me is how are bone and soft tissue tumors formed? Well, they're actually, if you think about the embryo is divided into 3 layers, your mesoderm, your ectoderm, and your endoderm. And bone and soft tissue tumors are formed from mesenchymal stem cells or from pluripotential mesodermal cells. And these cells can differentiate down various pathways and form different types of connective tissues. They can form bone, fibrous tissue, fatty tissue. They usually form a matrix, but there is a group of tumors that actually do not form matrix, and they're usually classified as small round blue cell tumors. The pathologists have classified all these types of tumors and have given them their names based on the type of tissue that they are trying to produce. So if a tumor is producing bone, it's an osteoid type producing tumor. The benign variety would be called maybe osteoblastoma, and the cancerous variety osteosarcoma. The malignant varieties of bone and soft tissue tumors are called sarcomas, and that's based how they look grossly. They have an appearance that looks mostly like fish flesh, and that's where the term sarcoma comes from. I think we're all very familiar with our carcinomas, which are our most common tumors that come from either ectodermal or endodermal cells, like our breast cancer, lung cancer, kidney cancer, GI cancers. And sarcomas are a rare type of tumor that come from a different layer of cells that form different types of tissues. So just to go over some common names that you may have heard of, here's a list of our most common types of benign bone tumors. This is a osteoid osteoma, right, where you have a small nidus in the proximal femur. This is an osteochondroma. Here's an enchondroma, neoplasm that has some calcifications within it, a benign cartilage tumor. A chondroblastoma, which tends to occur in the epiphysis, is a very well circumscribed lesion causing pain, almost always confined to the epiphysis. Giant cell tumor, which is one of the most common benign aggressive tumors in an adult between the ages of 20 and 40, and simple bone cysts. These benign type of tumors can have different behaviors. Some will sit there and do nothing and just weaken the bone, and some will grow and aggressively destroy the bone like a giant cell tumor. And obviously those ones that are aggressively destroying the bone, they have to be treated more aggressively than just observation. Here's our most common malignant bone tumors, or our most common bone sarcomas: osteosarcoma, Ewing sarcoma, chondrosarcoma. Right, osteosarcoma is our most common. There's about 600 cases in the country a year, usually occurring in children and adolescents. And it's called an osteosarcoma not because it's a sarcoma developing in bone, it's because it's actually producing bone. And that's why you see this fluffy, cloud-like appearance to it, or subtle sclerosis in it. That's actually a very bad radiological sign when you see it. Ewing sarcomas don't produce anything, so you'll never see any sort of mineralization with it. All you'll see is some permeation in the bone of a lesion. When you know that there's a lesion in the bone and you can't make out where the beginning and end is, you know that that's a bad lesion. This is an example of a chondrosarcoma. Chondrosarcomas usually have calcification, heavy calcifications within it. And chondrosarcomas would be the most common bone sarcoma in an adult. These are some of our benign soft tissue tumors that are most common. Lipoma, which you can see up here on an MRI. The mass follows signal characteristics that are the same as the subcutaneous fat. Schwannomas, which you see down here, which happen to be one of the more common soft tissue tumors that I see. You could usually, on certain MRI sequences, seeing the nerve enter and exit the mass. Schwannomas are benign peripheral nerve sheath tumors that arise from the Schwann cells that coat the nerve or form the perineurium. Right? They often have a classic target sign on an MRI with a bright periphery and a central dark area. And I think if everybody thinks back to pathology, you have Antony A and Antony B areas histologically, and that's what you're actually seeing here. You're seeing the Antony A areas in center, which are more dense, and the more myxoid areas, which are the Antony B arranged around the perimeter. Myxoma is a common benign tumor. Fibromatosis is a benign aggressive type of soft tissue tumor. Schwannomas are usually painful, whereas the other ones are usually painless. And these are most common malignant soft tissue tumors. Liposarcoma, which you see up here in the right-hand corner, can have an appearance very similar to a lipoma on an MRI, especially if it's low grade, and has fatty tissue in it, but has these streaking bands through it often. Fibrosarcoma is one of the other most common undifferentiated pleomorphic sarcoma, which you see down here in the right lower corner, and synovial sarcoma. So just a word about MRIs of high-grade tumors, soft tissue tumors. They're very nonspecific. You could have 10 different types of malignant soft tissue tumors or soft tissue sarcomas that all have the same radiological appearance, basically a very big, heterogeneously enhancing mass on an MRI. Myxoid types of tumors can have a slightly different appearance. Myxoid tumors, the term myxoid means mucus producing, and they produce a myxoid type of substance that's filled with glycosaminoglycans that traps water and hangs onto water. So on your MRI scan, you often see on the T1 weighted image a mass that's similar to muscle in intensity, but on the T2 it almost looks like a light bulb lighting up. And it's very important to recognize that sometimes these can have a cystic appearance. If you've gotten an MRI without gadolinium, this high fluid uptake in it is often misdiagnosed as a cyst. So something to keep in mind when thinking about the pearls and pitfalls that go along with the diagnosis and management of these tumors. So sarcomas are very rare cancerous tumors that arise in the bone or soft tissues or the muscle layers. There's about 11,000 bone and soft tissue sarcomas in the United States per year, and this is relatively rare in contrast to lung cancer, in which there's about 150,000 cases a year. They affect children and adults, males and females. So you always have to keep them in your differential diagnosis when you're considering a patient's cause of pain. It might be the last on your list, but always keep that in the back of your mind that a person can have a tumor. Sarcomas are aggressive and they destroy the soft tissues. They metastasize. That's what classifies them as a cancer. The most common sites of metastases are to the lungs, the bone, and the liver. Most can be treated with limb-sparing surgery. So if you get a patient that's been told that they absolutely need an amputation, maybe direct them for at least a second opinion. They're often treated in conjunction with chemotherapy and radiation, and the majority are cured if they're caught before they've spread. So the 65-70% of these of the high-grade variety are curable. And there's about 125 orthopedic oncologists in the United States who take care of these. So there's not a lot of centers that actually treat these routinely, but we're one of them in New Jersey. But when you're going to refer your patient, you should really think about a center that specializes in it. So what are our signs and symptoms of sarcomas? Well, soft tissue sarcomas, it's counterintuitive. They're actually painless, okay, which sometimes throws people off. So they'll often present with a painless mass or swelling. Bone sarcomas, on the other hand, usually present with a dull aching pain. They may be associated with swelling or a mass and night pain. Patients often have a history of an injury or a sports-related type of issue or overuse or complains of overuse of the extremity. They can present with pathological fractures. They're often misdiagnosed as having a pulled or torn muscle, or sometimes as having a hematoma, especially when the patients sort of give you that red herring of some sort of minor injury that's occurred. And sometimes when they're seen in the office, they're misconstrued as being a lipoma based on just palpating the mass. In terms of working up patients that you see with a mass or suspected tumor, whether it's in bone or soft tissue, you should always consider the X-ray first. It's the best test for differential diagnosis of a bone tumor, and it's useful for certain soft tissue tumors that calcify. MRI is actually rarely useful for diagnosis. There's very few things that are diagnostic on an MRI. A few soft tissue masses are diagnostic, usually lipoma, schwannoma, and hemangioma. You can diagnose those, but very few other masses are actually diagnostic. MRI is most useful for determining the extent of the tumor and helping us plan our surgeries when we're going to do limb-sparing surgeries versus an amputation. CT scans are useful for detecting subtle mineralization in tumors or subtle bony erosions. And why that's helpful is that it helps us categorize the tumor into different categories and diagnose or come up with a differential diagnosis as to what it is. Is it benign or malignant? And what category? Is it a bone-producing tumor or a cartilage-producing tumor like the chondrosarcoma I showed? Bone scans are useful because many times benign bone tumors or malignant bone tumors are multicentric and they show up on bone scans as a positive finding. CT scans are important for sarcomas. First place that sarcomas go are CT to the lungs, so CT to the chest is very important. Now, one thing that I wanted to get across is that ultrasound is absolutely useless in evaluating masses. May be able to tell you if a mass is there or not, but if a patient's complaining of a mass and it's not palpable, but it's absolutely useless in the differential diagnosis, and I would never suggest using that. So just as a very basic, differentiating benign from cancerous bone tumors, if you happen to see some of these x-rays in your office, benign tumors are usually very well circumscribed. They have what's called a sharp zone of transition, meaning you can make out the borders of the tumor. Okay. Malignant tumors or sarcomas, bone sarcomas, are usually permeative or moth-eaten in nature. I think everybody remembers those terms from medical school or talking with radiologists. And you really can't make out the borders of where those tumors begin and end. And they may have associated malignant appearing periosteal reactions like a Codman's triangle or a hair-on-end appearance. Now, interestingly, if a tumor has a soft tissue mass associated with it, meaning it's destroyed the cortex and extended into the soft tissues, it doesn't necessarily mean that it's cancerous. Benign tumors grow aggressively too and extend into the soft tissues. And this is just showing you the difference between benign and cancerous tumors. If you look at the tumor up on the upper left, this is an osteoblastoma. It's a benign bone-forming tumor, but it's very well circumscribed. It has a continuous periosteal reaction around it. So this tumor has eroded the bone, the cortex, extended into the soft tissues, but it's growing slow enough for the body to respond to it and try to ward it off. This is an osteosarcoma, a malignant bone-forming tumor, where you can't make out the beginning and end of the tumor. It's permeating through the bone. You can barely see it. It's spread through the Haversian canals into the adjacent soft tissues and is forming this soft tissue mass around it. In this soft tissue mass, we see this fluffy white stuff that's almost cloud-like, and that's actually the bone production from the mass, which when we look at this, right away we say this is a cancerous type of tumor that's producing bone. We should be able to put it into the category of an osteosarcoma. This is a Codman's triangle up at the edge, where the tumor has destroyed the periosteum in the area where it's come out of the bone, but it's elevated the periosteum at the perimeter, and that triangle is a very worrisome sign. Now, down in the lower left here, this is actually a benign giant cell tumor of bone, a very aggressive, extensive one. And it's destroyed the bone, it's formed this enormous soft tissue mass, yet it's benign. It's not going to metastasize, but it's grown aggressively in the arm and naturally needs some form of surgery. The way you can tell that this is probably benign is if you look here at the junction of the tumor with the normal bone, you see a sharp cutoff or a sharp delineation. Okay, so some things to be aware of. Hematoma is diagnosed on MRI or ultrasound. That's something that you should definitely second guess. Sarcomas can appear very hematoma-like on either MRIs or ultrasounds, and often a patient that presents with a large soft tissue mass with that diagnosis can have an underlying sarcoma. Always remember a patient with a sports-related injury, that a tumor can actually mimic a sports-related injury. Cysts on an MRI, unless you've gotten an MRI with gadolinium, you can't tell definitively that it's a cyst. Myxoid sarcomas and synovial sarcomas can appear cystic. Popliteal sarcomas often mimic a Becker cyst, and I've seen several patients misdiagnosed as just having a Becker cyst without any radiological workup. Some soft tissue masses, despite being sarcomas, don't follow the rules, and they're actually soft to palpation and are not very firm, so they can be misconstrued as being a lipoma. And highly permeative bone lesions may be imperceptible on x-rays and require an MRI for evaluation. So very important to always examine your patient for swelling, because bone sarcomas, depending on the contrast of what you're looking at, may be difficult to see, and it'd be important to detect the swelling or a mass on physical examination. And also, patients who have pain make sure that their pain has gotten better in 6 weeks or so from the time you've seen them if you haven't gotten an x-ray or an MRI scan of them. And if they haven't gotten better, go that extra step and get the x-ray or the MRI. And these are just some examples of tumors that I've seen that have sort of been misdiagnosed or their diagnosis delayed for a while. This was a lymphoma of the tibia on the left that the patient kept on coming back to one of the clinics that I worked at, and nobody was examining her. She had a big mass around her knee. And you can see here, they were looking at the x-rays. It's barely perceptible on the x-ray, the abnormality. But look at the MRI. All of the marrow is replaced on the MRI. This is a patient who was a female runner, gave a history of a pull in her thigh, and based on the x-ray was diagnosed with heterotopic ossification in her thigh muscles, in her hamstrings. And she wasn't followed with x-rays over the course of time, and 6 months later or so, she presented with this, and this was ultimately biopsied and determined to be a synovial sarcoma that actually was wrapped around her blood vessels at this time, and she required a very high above-the-knee amputation. This is a patient with a fracture of the fourth metatarsal. If you look at it, it was diagnosed as a stress fracture, and you see that there's this sort of moth-eaten appearance, which was diagnosed as disuse osteopenia of the foot. Well, things did not get better in 6 weeks or 8 weeks, and an MRI was taken, and there was actually a soft tissue mass growing from the bone that turned out to be a Ewing sarcoma. This is a 16-year-old female with knee pain who said that her knee just all of a sudden swelled up after being injured. And you can see this high signal intensity in the quadricep muscle on the MRI scan. This was diagnosed as a hematoma, and unfortunately the surgeon went in and washed it out as though it was a hematoma. Again, these type of things that are related to sports injuries, always think, especially when there's a mass there, that it may not be a sports injury. This is a patient who was having elbow pain, and an MRI was performed. There was some swelling in the area, and you could see a mass here on the MRI that's similar in signal intensity to the muscle. It almost looks like the brachialis muscle. This is the radial head and the distal humerus. And on the T2, it was very high signal intensity on the T2. And because it was right next to the joint and shaped like this, it was diagnosed as a ganglion cyst. The person underwent three or four aspirations, nothing would come out, finally had a biopsy and was diagnosed as a myxoid liposarcoma. And the last thing I'd like to show you is that this is an example of a person who was misdiagnosed as having a Becker's cyst. Came in, felt a pull and some discomfort in the knee, and had a mass palpated in the popliteal fossa. The mass had, again, a similar appearance on an MRI as the way a cyst would look. However, there was no gadolinium given with this MRI. It was called a Becker's cyst and went on for quite a while before it was actually diagnosed. So I just want to summarize to always keep in the back of your mind tumors as one of the entities in your differential diagnosis. Granted, out of 100 patients, you'll see, maybe one is not going to be a tumor. But when a patient doesn't get better, or when they have swelling, or things are diagnosed as a hematoma or a cyst, always second guess that and either send them for consultation or do the further follow-up that's necessary and go ahead with your MRI scans or MRIs with contrast. Okay. Certainly. Does anybody have any questions? Yes, ma'am. So I would always recommend getting an MRI scan Okay, if we remember, the majority of sarcomas are going to actually be painless. So the fact that a person has pain, probably it's more likely that the tumor will be benign. So the question was, if a person has a painful mass on sort of their thorax and it palpates kind of soft like a lipoma, but could be a liposarcoma, how should you work it up? And really the answer is to go ahead and get the MRI and evaluate it with an MRI. Anybody have any other questions? Certainly feel free to, grab me during breakout sessions or lunch. Okay, but I'm going to now turn the mic over to our spine faculty. This is Dr. Charles Gatto, who's chief of our spine service.